We've all, sat in the doctor's office, rolled up our sleeve, and just braced for the pinch.
Right,
A
yeah.
little sting, maybe a tiny red bump. We accept that as totally normal. But what happens when you wake up 3 days later and that little red bump has turned into this massive angry welt
Mhm.
that literally feels like it's on fire?
It is, it's an incredibly jarring experience. You go from feeling really proactive about your health to suddenly wondering if you've been poisoned.
Absolutely.
Yeah.
Especially if you're one of the millions of people injecting a GLP-1 drug at home to manage your weight or
Oh,
diabetes.
for sure.
And suddenly you have this 4-inch fiery patch on your stomach. I mean, your first thought is probably pure panic. Like, did I do it wrong? Am I allergic? Should I rush to the ER?
And that panic is exactly why we need to talk about what's actually happening under the skin.
Welcome to today's deep dive. We have a remarkably dense stack of medical documents to get through today.
We really do.
We are looking at FDA prescribing labels for diagnostics like the APLSol test, the U.S. Army Medical Command clinical guidelines, clinical data on GLP-1 weight loss drugs, biologics, and even specialized documentation from the CDC's Clinical Immunization Safety Assessment Project, or CISA.
It's a huge array of sources, but, they all converge on one very specific, very common clinical hurdle.
Right. And our mission today is to answer a highly specific but crucial medical question for you. What exact protocol is followed if a patient experiences persistent post-treatment localized burning or pruritus?
Which is just the medical term for severe itching.
Right, severe itching. That lasts beyond 72 hours. We're going to map out exactly how clinicians triage, treat, and prevent these stubborn reactions. So, okay, let's unpack this.
Well, to really understand what clinicians do when symptoms persist beyond that 72-hour mark, we first have to establish why 72 hours is the magic number in all these clinical guidelines.
Because it's not just a random guess.
Exactly. It's not some arbitrary benchmark a doctor just made up. It is deeply rooted in our cellular physiology.
So before we can call something abnormal, I guess we need to understand the mechanics of what normal actually looks like.
Yeah, let's use the FDA label for APL-SOL as our baseline. ALL is a tuberculosis PPD test, and its prescribing label perfectly outlines the standard timeline for what we call a delayed type hypersensitivity reaction.
Or a DTH.
Right, a DTH. So when a foreign antigen is injected under the skin, T lymphocytes, which are a specialized type of white blood cell, they recognize it, they proliferate, become sensitized, and release chemicals called lymphokines.
And those lymphokines are essentially a distress beacon, right? Calling for backup.
Exactly. They sound the alarm.
Wait, let's pause there for a second. The text mentions that this backup includes the infiltration of basophils, monocytes, and neutrophils. But, for those of us who aren't immunologists, what are those cells actually doing to the tissue to cause a visible reaction?
Okay, so think of basophils like the body's chemical warfare unit. When they arrive at the injection site, they drop payloads of histamine.
Ah, histamine.
Yeah, and histamine's primary job is to make the walls of your local blood vessels just slightly leaky. That leakiness allows fluid and more immune cells to flood into the tissue.
Oh, I see. So the redness is the blood rushing to the area,
Mm-hmm.
and the swelling, the edema, is literally just that fluid leaking out of the vessels and pooling in the skin.
You've got it. And that vasodilation and fluid accumulation, well, it takes time to build up.
Right. It doesn't happen instantly.
No, according to the data, in most sensitive individuals, this intense delayed hypersensitivity reaction first becomes evident about 5 to 6 hours after the injection. And it mathematically peaks at 48 to 72 hours.
I like to think of a subcutaneous injection like a controlled demolition inside the body.
Oh, that's a good way to look at it.
Yeah, you press the plunger, the building comes down, and a massive cloud of dust kicks up. That dust, the cellular infiltration, the leaky vessels, the swelling, it naturally takes about 2 to 3 days to reach its maximum height and then start to settle. If the dust is still rising after 3 days, that's when you know something else is going on.
That is an excellent mechanical analogy, and clinicians do have to account for a couple of notable exceptions to that 72-hour rule, though.
Like what?
Well, for instance, in geriatric patients, or those whose immune sensitivity has naturally waned over time, their metabolic and immune responses develop much more slowly.
So they're just on a delay.
Exactly.
Yeah.
In those older populations, a completely standard reaction might not actually peak until after 72 hours.
Okay, so age Changes the timeline, which totally makes sense. But what about the actual physical properties of the medicine itself? Because we have a lot of data here on GLP-1 medications like semaglutide and tirzepatide.
Oh, yeah, those completely change the game
Yeah.
because they are sustained release formulations. When you inject a GLP-1 subcutaneously, it creates a depot.
A depot, like a storage facility.
Essentially, yes. It forms a small physical reservoir of the medication sitting right there in the fat tissue just beneath the skin.
Weird. So it just sits there.
It doesn't dissipate immediately, no. It's engineered to release slowly over days or even a full week. And because that physical depot is just sitting there, it can continually poke at and irritate the local tissues and nerve endings.
That sounds uncomfortable.
It can be, but here is the key. Even with that continuous physical irritation, the standard erythema, the redness, and the swelling still typically follow the rules and peak within that same 24 to 72-hour window.
Okay, so let's put ourselves in the clinic. The 72-hour window has officially closed. The dust from our controlled demolition is not settled, and the patient's burning or itching is either persisting or getting worse.
Right.
How do clinicians play detective to decode what is actually happening in that tissue?
Well, the triage protocol kicks in, and it's basically a process of elimination. The clinician has to differentiate between a standard reaction that's just taking its time, a delayed hypersensitivity, a granuloma, or, obviously most pressingly, an active infection.
Let's start with infection, because that seems like the scenario you absolutely cannot ignore. What are the specific clinical red flags that elevate this from just a nuisance to a danger?
The big one is spreading redness. The protocol states that if the erythema expands beyond 3 inches from the original injection site, that's a major warning sign.
3 inches. Wow.
It's significant. And if that spreading redness is accompanied by purulent drainage, meaning pus, or you see red streaks extending away from the site, or the patient has a fever over 100.4 degrees, the protocol dictates immediate medical evaluation.
Because at that point, you're not just dealing with the medication anymore.
Exactly. You are no longer managing an injection site reaction. You are looking at cellulitis or an abscess.
Spreading redness, pus, and fever equal infection. Check. But what if it's not an infection? What if it's just incredibly delayed? The sources mention a very specific phenomenon with the Moderna mRNA 1273 vaccine.
Yeah,
And
the so-called COVID arm. This completely threw people off when it first started happening.
I remember hearing about that.
Yeah, it is a textbook example of a very delayed type 5e T-cell mediated hypersensitivity.
Wait, how delayed are we talking?
In clinical observations, this reaction didn't peak at 72 hours. In fact, it often didn't even begin until around day 7.
Day 7.
Yeah, with a clinical range of 5 to 11 days post-injection.
That is wild. I mean, you get your shot, you feel totally fine for a whole week, you think you're in the clear, and then suddenly your arm flares up out of nowhere. Why does it take a full week for the body to react?
It's because of the specific immune pathway involved. A type 5e reaction relies on T cells.
Okay.
Unlike a histamine response, which is nearly instant, these T cells have to recognize the antigen, travel to the lymph nodes, get activated, multiply, and then travel all the way back to the injection site to mount an attack.
That sounds like a whole commute.
It is. That entire biological march takes about a week. When they finally arrive, it presents with large redness, warmth, and intense itching, and it typically lasts about 5 days before resolving.
Wow, okay, so spreading redness means infection. A 7-day delay is a T-cell march. But we also have data on something called a granuloma, specifically pulling from research on subcutaneous peptide injections like TB500.
Right, granulomas are a completely different animal. If a reaction lasts beyond 10 to 14 days and it forms a firm, painless nodule under the skin, the protocol points to a sterile granuloma.
Why does the body build a hard lump?
It happens when the immune system's macrophages, which are kind of like the cellular garbage disposals, can't quite clear away the injected material.
So they just give up.
Sort of. Rather than letting it float around, they essentially build a fibrous wall around it to quarantine it. And what's fascinating here is how intense pruritus itching is actually the hallmark distinguishing an allergy or hypersensitivity from a standard irritation or a granuloma.
I'm going to push back on that for a second, though.
Sure.
If I have a cut that's healing, it gets itchy, right? So my injection site is incredibly itchy after a week. Isn't that just a sign of the skin healing itself?
It's really a matter of degree. A healing wound might have a mild, generalized tickle as the nerve endings repair.
Yeah.
But the intense, maddening, persistent pruritus we see in these specific reactions is actively driven by immune mediators like histamine and cytokines. It's a loud chemical alarm bell.
Oh, I get it.
If it itches intensely, you are dealing with a hypersensitivity.
Oh.
If it's just a firm, painless lump with no itch, it's a granuloma walling something off.
Okay, so the patient and their doctor have run through the triage. They've established that the persistent burning and itching isn't a severe bacterial infection requiring a trip to the ER. What is the immediate at-home clinical protocol for symptom relief? Like, how do we literally put the fire out?
Well, the clinical protocol is incredibly specific about temperature management. It strictly advises cold compresses.
Just cold.
Yes, 10 to 15 minutes at a time, always making sure the ice or cold pack is wrapped in a cloth to protect the skin from frostbite.
And the sources emphasize that heat must be avoided for at least 48 hours. I mean, the guidelines for recovering from a cortisone shot, for instance, explicitly forbid heat. Hold on. My first instinct when my arm aches after a flu shot is to stand in a hot shower or use a heating pad. Why is heat the enemy here?
It goes back to the mechanics we talked about earlier. Heat causes vasodilation. It physically expands your blood vessels.
Opening the floodgates.
Precisely. If you have an active inflammatory response where fluid is already leaking into the tissue, applying heat opens those vessels wider, inviting more immune cells, more fluid, and more inflammatory mediators into the area.
Oh, so you're literally feeding the fire.
Exactly. You want cold to constrict those leaky pipes and force the swelling down.
That makes so much sense when you explain the plumbing of it. So cold compresses only. What about topical and oral relief for the itching?
For localized skin inflammation, the protocol calls for applying 0.5% to 1% over-the-counter hydrocortisone cream very sparingly, or just using plain aloe vera gel to soothe the surface.
Seems pretty standard.
It is. But if pruritus, that intense, deep itching, is the main issue, topicals won't reach deep enough. The protocol steps up to oral antihistamines.
To block that chemical alarm bell you mentioned.
Yes. Clinicians recommend second-generation options like cetirizine or loratadine, primarily because they are non-sedating.
Which is important if you have to work.
Right. If a patient uses a first-generation antihistamine like diphenhydramine, which most people know as Benadryl, they have to be acutely aware of the sedative effects, which can impair their ability to work or drive.
And what about the burning?
For persistent burning or deep tissue tenderness, standard pain relievers like acetaminophen or ibuprofen are the go-to.
Got it. Now, there's also this massive bolded warning in the protocols regarding skincare. Keep the site clean and dry, and absolutely, under no circumstances should you scratch it.
Yes.
But beyond just, you might make it bleed, why is scratching a persistent reaction so universally forbidden by clinicians?
It comes down to preventing a secondary complication. Think about your skin. It is an incredible barrier, but it is constantly covered in millions of microscopic bacteria.
Yeah, that's true.
When you have an injection site reaction, that skin barrier is already stretched tight, stressed, and highly inflamed.
So the structural integrity is totally compromised.
Exactly. When you scratch, you create invisible microabrasions. You are essentially taking the bacteria from under your fingernails and rubbing it directly into a highly vascularized, inflamed wound.
Takes.
You can very quickly turn a simple, sterile immune annoyance into a raging secondary bacterial infection like cellulitis.
So you turn a 5-day annoyance into a major medical crisis requiring antibiotics just because you couldn't leave it alone.
Yes. Which is why aggressively managing the itch with cold compresses and oral antihistamines isn't just about comfort.
It's preventative.
Exactly. It's a preventative medical measure.
But what if home care fails? The cold compresses aren't working, the burning persists, the patient is miserable, and they escalate to their healthcare provider. What does the clinical escalation protocol look like?
This is where we looked at the U.S. Army Medical Command clinical guidelines. They have a very structured, objective way of categorizing these reactions by sheer size.
Just measuring them with a ruler.
Pretty much. They define a mild reaction as less than 50 millimeters in diameter. A moderate reaction is 50 to 120 millimeters. And a large reaction is anything over 120 millimeters.
Over 12 centimeters of redness and swelling. I mean, that is significant.
It is a massive area of tissue to be inflamed. For those large, persistent reactions, the protocol moves beyond over-the-counter treatments. Clinicians may prescribe high-potency topical corticosteroids.
And if that doesn't work?
Well, if the reaction is severe and causing systemic distress, they may bypass topicals altogether and prescribe an oral corticosteroid taper.
The guidelines mention prednisone for that.
Yes. A typical regimen might be prednisone at 50 to 60 milligrams per day for 3 to 4 days, followed by tapering off the dose over the next 2 to 4 days.
Which basically acts like a chemical off switch for the immune system, forcing the inflammation to shut down.
That's a really good way to look at it.
And sometimes the immune system's on switch is triggered by something completely unexpected. There's a fascinating extreme case study in our sources about a delayed inflammatory reaction to a hyaluronic acid facial filler.
Oh, that case is incredible. It perfectly illustrates how interconnected our bodily systems really are.
Walk us through it.
So, a patient had a sudden, severe delayed hypersensitivity reaction to her facial filler months after getting it. Her face just swelled up. And clinicians traced the trigger back to a transient bacteremia.
Let's translate that. They realized she just had a few stray bacteria floating around in her bloodstream. And the source of those bacteria,
A minor scratch on her hand from gardening.
that is just wild to me.
It is. The immune system detected the bacteria from the gardening scratch and ramped up its defenses. And in that heightened state of alert, it started scanning the entire body for threats.
It's like a computer running a hypersensitive virus scan, and it accidentally flags a perfectly safe file, the facial filler, as malware, and just quarantines it.
That is the perfect analogy. The immune system suddenly recognized the previously well-tolerated facial filler as a foreign invader and launched a massive attack on her face.
Of the panic she must have felt. And the clinical protocol to fix that specific case was intense. I mean, they couldn't just give her an antihistamine.
No, not at all.
They required 150 units of Hylenex, which is an enzyme injected to physically dissolve the filler, plus 2 separate courses of antibiotics to clear the bacteremia, and a 2-week prednisone taper just to calm the system back down to baseline.
It really highlights how aggressive these localized reactions can be once the immune system decides something doesn't belong there.
And what if a clinician is completely stumped? Say a patient has a reaction to a vaccine or a biologic that doesn't fit the U.S. Army sizing guidelines, doesn't match the COVID arm timeline, and standard tapers just aren't working.
Well, the CDC has a safety net protocol for that. Clinicians can escalate complex individual vaccine safety questions to the Clinical Immunization Safety Assessment Project, or CISA.
How does that actually work in practice? Like, who do they call?
It's a national network connecting vaccine safety experts from the CDC with specialists at major medical research centers. They provide free peer-to-peer expert consultations.
Oh, that's awesome.
Yeah, so a local doctor can literally call in a team of national experts to help them navigate highly unusual, persistent adverse events.
So what does this all mean? The immediate fire is put out, the patient's arm or leg or face is back to normal, but they still have a chronic condition.
Right, the underlying issue is still there.
Exactly. They still need their medication, whether it's a biologic for severe atopic dermatitis, a GLP-1 for diabetes, or venom immunotherapy. How does the protocol change for their next injection to ensure we don't go through this entire nightmare all over again?
This brings us to the preventative protocol. It's all about manipulating the variables we can actually control.
Okay, what's the first step?
The first pillar is pre-medication. The U.S. Army protocol, specifically for patients with a documented history of large, itchy local reactions, recommends pre-treating the body with a second-generation antihistamine.
Like fexofenadine at 180 milligrams or cetirizine at 5 to 10 milligrams.
Correct. But the key to pre-medication is timing. The protocol states you must start the antihistamine 24 hours prior to the injection and continue taking it for 48 to 72 hours after.
Oh, I see. You're trying to get ahead of the basophils. You want the antihistamine already circulating in the bloodstream, guarding the receptors before the chemical warfare unit even drops the histamine.
Exactly. You preempt the chemical alarm.
Okay, so we've prepped the immune system. What about the medication itself? We talked about the GLP-1 depot earlier.
Temperature plays a surprisingly huge role here.
Really? Temperature?
Yes. Most of these advanced injectable biologics and peptides are stored in the refrigerator to keep them stable. If you take a syringe of cold liquid and inject it directly into 98-degree subcutaneous tissue, it causes a thermal shock.
Oh, man. The blood vessels freak out. You get immediate intense vasoconstriction, which is then followed by a massive inflammatory rebound as the body tries to warm the area up.
It's entirely avoidable tissue trauma. The protocol strictly dictates letting refrigerated medications sit out and reach room temperature for 30 to 45 minutes before injecting.
Just leaving it on the counter for a bit.
That one simple step drastically reduces local irritation.
And then there is the real estate itself. Where on your body are you actually putting the needle?
Right. Site rotation is absolutely non-negotiable in the clinical guidelines. You must never inject into an area that is already irritated or recovering.
Okay, that makes sense.
Meticulous site rotation is required, and the guidelines actually suggest leaving a patch of skin completely unused for 3 to 4 weeks.
3 to 4 weeks. That seems like an incredibly long vacation for a piece of skin over a tiny needle poke. Why so long?
Because clinicians are trying to prevent a condition called lipohypertrophy.
A lipohypertrophy.
Yeah, if you repeatedly inject a medication, especially a depot medication, into the same small area of tissue, the constant microtrauma from the needle and the localized chemical effects of the drug cause the subcutaneous fat to thicken and scar.
Oh, wow. So the fat changes structurally.
Yes, it forms hard, rubbery, fibrous lumps under the skin. And it's not just a cosmetic issue. That scar tissue is largely avascular, meaning it lacks good blood flow.
Which means if you inject your medication into one of those rubbery lumps, it's just going to sit there.
Precisely. You could be injecting a $1,000 life-saving medication into a lump of scar tissue, and your body isn't absorbing it properly.
That's a huge problem.
It is. Your blood sugar won't drop, or your autoimmune symptoms will flare, all because of poor site rotation.
But practically speaking, it's really hard to remember exactly which 2-inch patch of your thigh or stomach you used 3 weeks ago on a Tuesday.
It is, which is why clinical documentation is the final pillar of prevention. Clinicians highly recommend using visual tracking apps or simply taking time-stamped photos of your injection sites and any resulting rashes on your phone to track the patterns.
Just snap in a quick picture.
Yeah. If we connect this to the bigger picture, empowering the patient with these preventative techniques, understanding the 72-hour window, pre-medicating, warming the drug to room temperature, religiously rotating sites, and documenting everything, it ensures they don't abandon life-saving therapies out of fear of manageable local side effects.
It puts the control back in the patient's hands, taking away that anxiety of the unknown.
Exactly.
So to wrap all of this up for you listening, while waking up to burning, swelling, and itching that lasts beyond 72 hours, can absolutely induce panic, understand that it's usually a localized immune response.
Nothing to panic over.
Right. It is a sign that your cellular defense mechanisms are doing exactly what they evolved to do over millions of years, protecting you from foreign material, albeit a bit too enthusiastically.
It's an incredible biological system, even when it's inconvenient.
But by utilizing cold compresses instead of heat to manage the blood flow, preemptively leveraging antihistamines, practicing meticulous site rotation to protect your tissue, and knowing exactly when spreading redness warrants a call for clinical steroids or antibiotics, you can safely navigate these reactions.
Knowledge is power here.
Remember, your body is constantly communicating with you. A persistent reaction isn't a failure, it's just data. Tracking these symptoms empowers you and your doctor to make precise, educated adjustments to your treatment plan. Which leaves us with one final provocative thought to mull over. As the landscape of medicine shifts more and more rapidly toward self-administered at-home injectables.
And it really is moving fast.
Yeah, everything from advanced autoimmune biologics to absolute blockbusters like GLP-1 weight loss drugs. We have to wonder, will our own hypervigilant immune systems, rather than the complex diseases themselves, become the greatest hurdle to these modern miracle therapies?
It's a fascinating medical paradox. We are engineering incredible targeted treatments, but we still have to figure out how to sneak them past the body's ancient, heavily armed border patrol.
It's like trying to explain to the site foreman that the controlled demolition is actually supposed to be happening so they can stop sending in the emergency crews and raising the dust. Keep an eye on the dust, stay informed, and we'll see you on the next deep dive.